And Markus Stock from MedAustron will present on treatment planning methods at MedAustron. Markus, please, you can share your screen.
Yes, thank you very much for the introduction. Let me just see if it works to share the screen. I should come in a second. And I start a PowerPoint.
Okay, we see full screen and we hear you very well. Please go ahead.
Right.
Thank you.
Thank you very much. So it's my pleasure to give you some insight into our treatment planning methodology. So of course I will not have time in these 15 minutes to introduce to the overall challenges of treatment planning, but for that reason, I try to focus on what we have specifically implemented, and maybe you cannot see it at every other particle or proton or carbon facility, and therefore I would like to just give you a short overview about MedAustron. I'm aware that you have seen, I think, a video this day or the day yesterday, but I would like to focus it more in the focus of treatment planning, and then I would like to address some proton planning and carbon planning aspects, and maybe tell you also a bit of what are our future developments or where we would like to go in treatment planning. And all the background I can provide you here is, of course, biased by the indications which we treat at MedAustron, which were referred to us. And here you can see, let's say, that the numbers in terms of, so up to now, we were treating close to 1,000 patients within the last nearly 4 years. And we are mainly having experience on SID and ESP tumors, as well as head and neck re-irradiation scenarios, pediatric patients, and the more classical indications like sarcomas and chordoma and chondrosarcomas. And this is, let's say, the big portion of indications which we have seen up to now, and that's also the experience which we can translate and can transfer to you. So you might know, of course, that we are a dual particle facility providing protons and carbon ions with energies similar to what Marco presented before in terms of protons energy range translating into 3 to 38 centimeter in water, as well as carbon ions translating into 3 to 27 centimeter of penetration depth in water in overall at the end, then to 3 clinical rooms and 1 related research room, which is similar equipped than the treatment rooms. Although you can see here that the treatment rooms are having a different configuration. So at the moment we are operating 2 rooms with a horizontal and a vertical, as well as 1 room with a horizontal room, and we are soon starting to treat early next year the proton gantry. But for the moment, we are treating with fixed rooms mainly. So that is, let's say, the roadmap to our completion. So we are here 2021. So we have carbons in vertical and horizontal beam available. We have protons in the rooms available, but our proton gantry will kick in by the end of this year, beginning of next year. And then we have all our 3 clinical rooms in full operation, having at least the proton gantry option. And that will, of course, also expand our indication mix to other indications which we could not treat up to now. One speciality, I would say, which we early on implemented in terms of requirements, which we early on implemented in terms of functionality, is the possibility to treat non-isocentrically. Why is that? In terms of treatment room configuration, you can see here that usually you have the isocenter and the patient located in isocenter position, that you can fill or treat the patient with in that case, both beam lines in this IR2 assembly here, so the horizontal and the vertical beam line. But having, let's say, the 2 beam lines separate from each other, meeting in the isocenter, means that you have a large air gap from the vacuum window till the particles reach the patient, and that's not so much an issue for heavier ions, but for protons it's quite an issue, as they scatter more the more they see air, and the more they penetrate through air, and that reduces the sharpness of the beam dramatically, and also reduces the usability of those beams then for sparing organ risks, and for being more beneficial than photon treatments, for example. And for that reason, we designed in the software workflow, but also in the hardware-wise, the patient positioning system is such that we can move the patient close to the nozzle exit window and treat non-isocentrically. And by that, we could achieve a beam penumbra reduction of 30 to 40%. And this is shown by the graph over here, where you can see. Let me see if I can switch on the laser pointer. Yes, where you can see our spot size in comparison to commercial systems like IBA or Varian proton beams, as where in an isocentric manner, our spot size would be bigger than the commercial solution. But as soon as we move the patient with his head treatment, like over here, from the isocentric to non-isocentric condition, we could achieve even sharper spots. And the spot is in full width half maximum in millimeter as a function of energy here, and can produce sharper spots even than the commercial solutions. So that is a clear benefit and a planning benefit to produce sharper dose follow-ups. And you can see here demonstrated on a clinical plan how this translates then into dosimetrical advantages. So you have here a pediatric patient, and the dose distribution generated by two beams coming, let's say, from a vertical beam line and coming from the side. You see how the lower isodose contribution blows up if you have an air gap of 54 centimeters, and that would be the situation of isocentric conditions. As soon as you can reduce it to 23 centimeters, non-isocentric conditions, you can narrow down the beam penumbra and make the treatment more conformal than in the isocentric setup. And you can see how this translates into like brain tissue here, lower doses in the brain tissue. So the solid line is here, the isocentric condition, and the dotted line is the non-isocentric condition. So you can even spare more normal tissue, also shown here in the dose difference map, if you subtract this dose from the isocentric dose. And you can see all around the tumor, which is situated here, you would have an higher dose contribution for isocentric setup. Another way to further reduce spot size is using a bolus, so not having the range shifter in the nozzle used, but a range shifter attached to the patient, which sometimes is feasible. And by that, you also can narrow down the beam penumbra quite dramatically, which is often a useful tool in pediatric patients where you're very interested to narrow down the low dose path even further compared to photons. And then also here you can see how much impact this is to have a further range shifter attached to the skin with such a bolus. Another way is also, and that's a technique which we implemented from the beginning on, is to split the field into a portion which is delivered with a range shifter whenever it is needed to be superficial. So here we have a brain tumor, which is from in-depth going to superficial portion of the patient's head. And we give the dose to the superficial part with a range shifter, which is a physical scatterer, acting as a physical scatterer in the treatment nozzle. And the portion of the tumor which is deeper situated, we deliver without the range shifter in. So we move it out, and by that we can get a very sharp penumbra still in depth, even sharper than on the surface. And if you build a dose difference, then you can see again the very good benefit of this technique of splitting up the beam into two, coming from the same direction. So by that we can increase the beam quality. Another aspect we have to have in mind is Marco was addressing this before. CNAO is working multi-energy extraction similar than MedAustron is doing for a good reason. That treatment times with synchrotron technology, as implemented in the PIM study, is generating beam on times still exceeding the ones of cyclotrons, for example, just by the fact that you need to have the cycle of extraction of energy, washing the magnets, inject another time, and get another energy out of the synchrotron. And by that, you have beam on times, which is sometimes too long for clinical treatments in some indications. And that's why we at MedAustron do a lot of beam splitting or alternating beam sets. That means on one treatment day, we use 2 beams arranged like for these head patients over here. And on the second day, we add 2 more beams and have the patient just positioned differently. And by that, you can have 4 beam directions, making the plan more conformal and more beneficial, and it can be still treated in a faster treatment slots within 1 day. So it makes it more efficient in terms of treatment delivery, while you are not losing quality of the treatment plan by using already 4 beam directions, which is more of a standard with conventional cyclotron accelerators. Then, of course, the longer the treatment takes, robustness of plans is an issue for us. So how sensitive are our treatment plans to movements of the patients in terms of during diffraction or from fraction to fraction, as well as how sensitive are we in being precise enough to determine the stopping power ratio of the material of the patient. And that's why we invest a lot in using robustness evaluation tools to analyze how robust is it in terms of PTV coverage, CTV coverage, as well as organ risk sparing. And finally, we also use robust optimization tools to be smear out the effects of filling and emptying nasal cavities, like in the head and neck scenario, where we have here the nasal cavities, which might be treated from different directions. But depending on the nasal cavity filling status of the day, you might have a huge impact on where the dose is deposited. And if you patch fields together, like you can see over here, so to patch a lateral field with a vertex field giving from this direction, you can optimize the plan in such to have shallow gradients, and you don't have that high impact on how the nasal cavity filling status of the patient is on that day. So it minimizes this influence. So these are some sort of, I would say, special techniques besides MFO, SFO treatment technologies using active scanning technology, which are special, I think, especially utilized at MedAustron. When it comes to carbons, our rationale to use carbon ions is at MedAustron, whenever there is macroscopic disease, whenever there is local control, which is difficult to achieve with low LET radiation like protons or photons, or also when it's expected that local control can impact survival, and also in certain re-irradiation scenarios. And then we always take the advantage of the specificity or the distinction of carbons to protons, which is, of course, that the penumbra remains sharper in depth, but also in distance to the nozzle in terms of air gap. That is, let's say, one motivation. And also the second motivation is to use the high LET part in the last part of the beam path in a spread out Bragg peak. Then, of course, it comes at a cost, and that the cost is the fragmentation tail of carbon ions. But usually the impact of fragmentation tail is minor or very low. When we entered the arena of carbon ion therapy 2019, we of course needed to decide to which RBE model we would like to stick to, and you might know there are two schools or two routes, mainly the Japan approach using the MKM model or the local effect model approach, originated at GSI in Germany. And we stick to the local effect model as it was implemented in our clinically used race station treatment planning system. Although we have a program we would like to translate from local effect model to RBE to MKM models in the near future to be able to extract carbon experience from Japan. And hence we stick. Yes.
If I could ask you to please wrap up sometime soon. We are over time now.
Yes,
yeah,
there are just a few slides, so 3 to 4 slides. Thank you very much. So spot size wise, we are very sharp with carbon ions compared to protons, and by that we can establish very steep gradients of 60 gray within 10 millimeters, as you can see over here. But we need to at least cope with the issue that that we don't have carbon ion gantry available as it's in Heidelberg. And the approach how we deal with that is mainly to rotate the patient. And for that reason, I show you this example of a re-irradiation scenario of rectal cancer where we have close proximity of the tumor to organ at risk like to ureter. And we immobilize the patient twice. That means once the patient is supine, prone position and lifted up on the left and lifted up on the right. And by that we can mimic actually a gantry approach coming from different directions. And let's say this is the CT lifted to the left, this is the CT lifted to the right. And if we create the overall sum, it looks like we have a gantry available and can use these beam angles, which are the most beneficial for those patients. So with a complicated patient setup, we are able to mimic then at least having or pretending a gantry and have the same treatment quality, so to say. Also, it is, of course, increasing the complexity of planning and patient setup. Okay, so with that, I would like to just address in half a minute our further projects. We would like to implement LET optimization clinically in our treatment planning system. That's a PhD project we're currently running at because it's seen in the clinical data that it's beneficial, at least for large size tumors, to be able to translate the high LET part to the center of the tumor. But also here, a study shows that high LET distribution in the GTV is more important than coverage with those. So that's an indication that this is beneficial. And by that we can more specifically address hypoxic areas in the tumor and boost those or boost LET and RBE to these parts of the tumor. Okay, that would be it from my side, and thank you very much for the time to present here, and thank you very much for your attention. And I'm open for questions then, of course.
Thank you very much. I see that there is no time for questions. Maybe you can fast answer this question.
Can you please briefly explain patient care procedures in MedAustron? What type of detector do you use for treatment plans, measurement? And yes, so usually we use a 3D block of pinpoint ionization chambers in a water tank, and up till February this year, all plans were verified with this block of pinpoint ionization chambers. Overall, it's 24, but just recently we switched to a Monte Carlo-based solution from IBA called MyQA Ion for protons in the horizontal beamline, and we in the future plan to implement a gate-based or Xion-4 gate-based Monte Carlo tool for further optimizing and reducing the measurement workload for carbon ions. But that is still in the future. At the moment, we partly substitute measurements up to 25–30% by Monte Carlo tools.
Okay, thank you very much. And now we can